Thank you. I'm so excited to be here, so thank you very much. As Robbie kind of mentioned, a lot of the pediatric management theories have kind of trickled down from adults, and we certainly have more data, more tangible data in adult patients, and then a little bit more in pediatric patients, and not as much in neonatal patients. And so I think you'll probably agree it's sometimes a real struggle to very scientifically manage these patients. So we have to use the tools that we have. And what I'll present is something a little bit provocative and perhaps a different way of thinking when we talk about non-invasive ventilation for very premature infants for their neonatal period. These are some of my disclosures. There are many differences with neonates than even pediatric and adult patients, right? There's not a lot of data. We don't have large randomized controlled trials to base a lot of our management strategies on, which provides, it just makes things very difficult as we're trying to care for our patients in a very scientific and evidence-based way. A lot of, especially premature infants who perhaps have, precipitous deliveries or unplanned deliveries, their parents don't quite consent as high as Robbie's patients might because it's such a vulnerable period. It's a vulnerable patient, and parents in those instances kind of don't want to even think about research, and so it's a large struggle. The other thing that we don't have in neonatal patients is sedation, right? A lot of these premature infants who are born, they can't be sedated for months, as they're growing and developing lung tissue. So we like to keep them awake, interactive with their environment, breathing spontaneously. But again, that lack of sedation or passivity, as Robbie was saying, doesn't allow us to get things like adequate plateau pressures. Also, we use non-invasive interfaces most often, as well as uncuffed endotracheal tubes. And so that also provides some limitation in all of the measurements that we can get as we're ventilating these patients. The other thing that we don't have are significant technologies that are available in adult patients, like esophageal catheters. EIT, which is something that, at least in my world, is up and coming with neonatal patients, but it's not nearly used with the frequency that it is in adult patients. Other things that are used in adult patients are frequent x-rays or perhaps CAT scans to look at lung inflation and lung disease progression. For newborns, especially premature newborns, you try to limit the amount of radiation. So those are technologies that we have, but that we can't use as often adult or pediatric patients, given that their disease in their hospitalization is likely to be much longer than a patient who has ARDS. I'm not going to go through these because Robbie did such a great job of them, but these are the things that we look at for ventilator-induced lung injury. Things like barotrauma, volutrauma, and Adelac trauma. I think in the neonatal world, I would assume it's true for you as well, but certainly in my world, barotrauma has been the large focus for decades. We've always been focused on pressure, reducing the pressure, making sure that it's as low as possible, seemingly with no respect to tidal volume or Adelac trauma. Even if the driving pressure was low and the volume was generous, we let that patient be, right? We wouldn't necessarily reduce the peak inspiratory pressure that we're using on the ventilator. With this notion of volutrauma also came the limitation of the use of PEEP, right? We always thought pressure was bad, and so the PEEP was always kept at a low level. Now we know that low levels of PEEP are good, except when you need high levels of PEEP. And actually higher levels of PEEP can be protective of the lung if you don't have that cyclic opening and closing on every single breath. So having the right degree of PEEP is actually better than just kind of always having low PEEP. Another thing I should have included in the previous slide is we don't have a great way of identifying what that optimal PEEP is for some of these neonatal patients. Another thing that plays a large role is surface tension. Back to Laplace's law, the radius has a great impact on the degree of surface tension on any alveoli. if you take out surfactant now, the tendency for it to collapse is then significantly higher. The pressure that's required to then reopen that alveoli is also significantly higher. So if we can get the alveoli open and keep them open, we're overcoming the surface tension, and then ventilation can be much easier. This is really the baseline treatment for premature infants. Hopefully we can get prenatal steroids into the mother that actually can boost surfactant production of the fetus before delivery. This is sometimes really tricky, especially premature infants. Sometimes the delivery is precipitous, it comes very quick. Prenatal steroids have to be given over a series of time, and it's 3 doses, and I'm blanking on the time frame, but so you have to somehow delay delivery to get the steroids in for them to be as effective. CPAP is then also something that's well known to help these patients in their breathing. As I mentioned before, as soon as you get the alveoli open, breathing is actually fairly easy for them. Surfactant replacement therapy is also well used in neonates, and this is something that's been used for decades. After babies are born, it's not up until really 5 days that they start to produce significant surfactant to stabilize breathing. Some people are leaning towards, or I guess the notion has been, surfactant replacement therapy should be given to all babies under 35-ish weeks, kind of prophylactically. As soon as you can, right after delivery, give surfactant. Now there's a bit of a shift towards place them on CPAP first, see if that distending pressure is enough, and allow the surfactant production to happen naturally. If the distending pressure is not enough of CPAP and you still have a high FiO2 requirement above 0.4, then people are turning to surfactant. So there's no data, right? So that's one of our struggles, but there are kind of 2 different sides to this, and I think both with very good reasoning. The approaches to surfactant administration have shifted over the last decade or so. The traditional approach has been place an endotracheal tube and instill surfactant directly through the endotracheal tube. Often what happens with that is you've now committed your patient to some course of mechanical ventilation. Sometimes it's related to their lung disease. Sometimes it's related to the medications that they're given for the intubation procedure itself. So you have to kind of think about that. And as we have less invasive or minimally invasive methods now to deliver surfactant, this could be a better way and a better approach to do so. There are things like Ensure. I'm not sure if you guys have heard of these or used these. Ensure is intubate the patient, give surfactant, and extubate right away. Lisa is using a laryngoscope to actually still instrument the airway, but then instill a small catheter into the trachea, and it gives surfactant that way. So you're not putting in any tube with this method, but you do still instrument the airway. SALSA is the primary method that we use at my institution, where we're using laryngeal mask airway or supraglottic airway, as the pictures show, and administer surfactant directly through that. All of these, though, when you extubate the patient or remove the airway, you have to then supplement that with non-invasive respiratory support, whether that's non-invasive positive pressure or strictly CPAP. This is not sufficient enough, especially in really preterm infants, just surfactant instillation itself to sustain spontaneous breathing. Non-invasive positive pressure ventilation gives both inspiratory and expiratory pressure. It has to be generated by a ventilator, but though can have different interfaces. There can be mask interfaces, prong interfaces. Some people even use a nasopharyngeal airway, so an endotracheal tube that kind of stays in the back of the throat, doesn't go through the vocal cords. And it just depends upon what your institution has available for resources. It has been shown that using NIPPV has a modest reduction in the incidence of BPD, as well as reducing the need for invasive ventilation. I would say non-invasive ventilation, NIPPV, is not as commonly used as straight CPAP, and I'll get to CPAP in a minute. And if you think about the mechanics of it, as long as you have alveoli open, the chest wall of a newborn is very compliant. If you have the airway, the alveoli open, then the subsequent inhalations don't require a lot of inspiratory pressure. It's pressure that they can generate on their own without significant effort. So really the respiratory system compliance of a newborn is very low. So needing inspiratory pressure is most often avoided, and we can just get away with nasal CPAP. Nasal CPAP does provide the distending pressure to the airways and alveoli. This can be generated by many different methods. You can use a ventilator, you can use a bubble CPAP system, which is fairly common in NICUs. There's also a flow driver system, which provides constant flow to generate the CPAP. And similarly, you can deliver it with many different interfaces. And the interfaces now are becoming increasingly available to different size neonates, which is really, really wonderful. What I'll say is that there is no demonstrated or documented superior system. There's data that supports many of them. I think there's pros and cons to all three of them. One thing that I really like about the ventilator is that when there's a leak in the system, either it alarms if the leak is excessive, or with leak compensation, the ventilator will add flow to the system to maintain that pressure. Because it's a device, it has that regulatory capability. Bubble CPAP, on the other hand, does not have those two functions. It's a fixed flow. Same thing with a flow driver system. It's a fixed flow. So if there's a leak, then there's a lack of CPAP that's transmitted to the patient. There is some data that suggests that the bubbling helps the oscillations and helps ventilation. Again, there's no documentation of a superior system, but it is what your institution has. Yeah, so I mean, these are all things that are well known, that having CPAP applied to the patient, having the alveoli open can reduce the work of breathing, reduce the degree of atelectasis, and reduce that atolect trauma that we see often. It's particularly effective when it's used prophylactically. So if you're waiting until the patient is struggling to breathe with, tachypnea, retractions, nasal flaring, it's probably too late to then initiate non-invasive support. Especially in preterm neonates, it's better to use CPAP prophylactically to keep the airway open, get them open and keep them open, and then the patient can breathe on their own. In 2021, there was a Cochrane review that looked at a bunch of papers, of course, that showed that using CPAP prophylactically reduced the need for mechanical ventilation and surfactant administration. I didn't kind of go into this, but surfactant administration, again, seems like a large staple in NICUs and something that we've been doing for decades. But instrumenting the airway can cause significant issues. Things like trauma, physically to the airway, but also other things like desaturation and bradycardia can have then further impact on actually the brain of neonates. So it's not really a benign procedure for sure. This is, I think, a study that may challenge the way that you think and the way that you manage patients. And it looked at, is this just published a couple months ago, early in 2025. It was a randomized controlled trial that looked at using CPAP over an extended period of time versus children using CPAP that were discontinued when they became stable. So patients who were in the extended group got CPAP for an additional 2 weeks after the clinicians at the bedside essentially thought that they could come off CPAP. The authors wanted to look at what the alveolar volume was at 6 months corrected age. So the hypothesis was, if we keep these patients receiving CPAP, perhaps this will promote lung growth. It will prevent this atolect trauma, perhaps of new alveoli that are still forming, and then the babies in 6 months further down the road will have better lung function and respiratory function. They also looked at the diffusion capacity of the lung as well as the forced expiratory flow, again, both at 6 months. And then they looked at FRC at the time of randomization and then 2 weeks later while the patient was still in the NICU to see if there were any more immediate effects. And this is what they saw. So the extended CPAP group are all in the bluish color, and the discontinued CPAP group is in the orange. So I'll start with the bottom right. That was the FRC that was measured at randomization and then 2 weeks later, and this was done through a nitrogen washout. And you can see in those patients that were on extended CPAP, their FRC was significantly elevated. When they then came back at 6 months of corrected gestational age, they were actually sedated, and a single breath hold maneuver was done, also with carbon monoxide and heliox washout to get some of these other volumes. But the alveolar volume was higher, meaning there's more alveoli available. The diffusion was better, and the forced expiratory flows were much higher in those infants that received extended CPAP. So, I know we try to limit the amount of respiratory support that we give patients. We try to get them out of the hospital sooner, get them home sooner. But what I think is challenging us in this is that this extended CPAP really does promote lung growth. This is now based on this and other studies that support this. This was just the strongest study so far. This is what we use at our institution for our practice, where patients who are greater than 32 weeks gestational age, corrected, who have been on CPAP of 5 and Romair FiO2 for at least 5 days can then come off CPAP, but they don't come off CPAP before that. Even if they're 31 weeks and have been on 5 of CPAP and Romair for 2 days, they continue to stay on CPAP, again, to promote this lung growth. One thing that I would challenge, and we don't know the answers to this yet, and it's something hopefully somebody will perhaps look into, is, we are using healthcare dollars, healthcare resources to continue the CPAP, right? There's many things that go along with this. And so, I don't know that the number of alveoli at 6 months is significant. What we need to think about are what outcome measures, things like rates of BPD, use of oxygen. Are there any impact on those things further down the road? What does their PFTs look like when they're 5? Do they have less likelihood of developing asthma as they get into their childhood years? All of those things, I think, are measures that we would like to understand as a result of using CPAP longer and perhaps having more lung growth. That's it. Thank you.
Thank you very much for your excellent lecture. I enjoyed. Is there questions and comments? Cho Sensei, どうぞ.
Thank you very much. You good presentation on the neonatal.
Yes.
And it's amazing. And only 5 days elongation of CPAP increased the FRC 2 weeks later.
Yeah.
I have many questions. Amazing. Elongation of CPAP may increase the body weight, body size, because the patient with positive air pressure can breathe easily and can drink much more, and the body size may be bigger.
Yeah.
And FRC increasing maybe due to the body size. And other question, nasal high flow could make the same effort. Later study to this corrected age, patient can wants to drink pills. So the nasal high flow is comfortable for babies than CPAP. So if the nasal high flow system make same effort as a same outcome, we have tendency to elongation of the management with nasal high because it is comfortable for babies and CPAP. So do you think about the nasal high flow system?
Yeah, I think it's really interesting. And the use of nasal high flow throughout all patient populations has increased. I would say that we need to do it a little bit cautiously. The baby looking more comfortable, I don't know that translates into FRC, right? Even in adults, we don't know what flow rates. We have an idea what pressure they generate. In a newborn, there's no data to determine that. If you need CPAP, then you should have CPAP, and we should figure out a way to make the baby more comfortable. We're working through this now, but what we're at my institution, we're looking at using EIT, and we've looked at many babies, and because the results are so powerful, I think we're wrapping up the manuscript now, where we looked at EIT and lung inflation and distribution of ventilation using a RAM cannula with a CPAP driver versus an occlusive interface with a CPAP driver. And there's great differences, meaning the occlusive interface with CPAP, the degree of recruitment is so much higher. And so, we didn't look at nasal high flow oxygen, but I would even put that below the RAM cannula with a CPAP system of the degree of pressure that it's actually transmitting to the lungs. So I do think that there are probably some patients that benefit from that flow and it reduces some work of breathing. But if you're really looking to apply CPAP to patients, we should give them CPAP.
ちょっと待ってくださいね。His first question, the CPAP makes body weight higher or the lung itself bigger? It's a question.
Yeah. So, and this is a real struggle that we have in neonatology as well, is that their body weight doesn't tell us what their lung size is, right? Like in adults, we have ideal body weight. And if any of you are going to be around tomorrow, I'm talking about using volume-targeted ventilation, and that's one real struggle that we have as the baby grows, is that body weight or is that lung development? And it's a real challenge to figure out. What I would say is that patients who do have increased work of breathing and difficulty breathing, they use some of their calories to breathe. And so perhaps these patients who have a reduced work of breathing, they might have a higher body weight. And I don't know that it's directly related to their lung growth, but it's perhaps that calorie expenditure is reduced.
Thank you very much. So, 中川先生、どうぞ。
Thank you very much for the lecture. I'm Satoshi Nakagawa, and I'm also interested in the extended CPAP study. And I'm wondering what will happen when the baby gets the age of 2 years old or 3 years old or 6 years old.
Agreed.
Because this reminds me that old UK oscillation study, which were done by Dr. Anguino, and the initial outcome in the oscillator group and conventional mechanical ventilation group are the same, no difference. But when we look at the school age population, lung function is much, much better with the oscillation group. But in the adolescent age, both are the same. So I'm wondering what would be happening in the next 3 years or 5 years.
Agreed. And I think that's, as I was saying, that's what we need to understand, right? We're spending a lot of time and resources and money doing this, right? We're perhaps preventing them from feeding orally, depending upon, the level of CPAP that they're on. And what are all of these expenses then produce? Is it just growth in alveoli? Does that mean anything? Or do we have improvement as the patient grows? And, we're just not there yet to understand that, but hopefully that is, being looked at.
Thank you very much. Is there another question? I have one comment. Your lecture reminds me that positive pressure, even we used intubation, positive pressure is not bad. I mean, when I treat congenital diaphragmatic hernia, maybe 10 years ago, I want to expect them earlier. So I want to expect earlier and earlier. So the duration of the ventilation getting shorter, but the results is the pediatric surgeon says after we try to shorten the ventilator period, and they must use the oxygen longer. But this is not the real. This is not the data published, but our impression is
Yeah.
to keep the lung open and reduce the respiratory effort is very important, even if we use the intubate and the endotracheal tube. So your lecture is the same concept. So to keep the lung open by the mask and reduce the work of breathing works well, right?
Yeah, yeah, and we were speaking of this yesterday, that definition for bronchopulmonary dysplasia is oxygen, being on oxygen. And so if discontinuing the CPAP means that they go on oxygen, is that better? I don't think so, to be honest. And again, there's no hard data to say yes or no, but you're right. Like we always try to go to the least invasive thing, but that may not always be what's best for the patient, either in the short term, but then even in the long term. So.
Thank you very much. 他何かありますか？大丈夫ですか？
I have one
Yes.
comment. Just comment. In fetal period, the fetal lung needs some PEEP or pressure from air amniotic fluid.
Mm-hmm.
So if the baby has low amniotic fluid pressure, the result is lung hyperplasia.
Yes.
So after birth, normal PEEP or low CPAP might have the defect to growth or develop the lung tissues. So physiological PEEP or just higher
Yeah.
PEEP might have some effort on function to grow
Yes.
lung tissues.
Yeah, yeah, and I think this also kind of supports that. Yeah, I was really reading to understand the physiology of the lung growth and whether this is something that, CPAP really impacts, or and it does seem to do so for I think those very reasons, because that's how lungs grow.
Just like the CDH.
Correct. Yeah.
So いいですかね。Thank you very much for your excellent lecture, and thanks for giving us the great ideas to keep the lung open and
Yeah.
keep the baby more safer way, right?
Yes.
Okay, thank you very much.